So hello everybody. Thank you for being here. I'm sorry I had to switch to Diana's computer. I welcome Dr. Anton Gietl. He is Chief of Services and Head of Clinical Studies at the Center for Prevention and Dementia Therapy at the University of Zürich and the Institute of Regenerative Medicine and the Psychiatry Hospital of the University of Zürich. And he leads the PET imaging and longitudinal cohorts. He has worked, of course, with Rajanich on the aducanumab story, and he works together with the group of Professor Hawk, looking at the interplay between biomarker, molecular biomarker, and imaging readouts. Welcome, Dr. Gietl.
Well, thank you very much for that kind introduction. Thank you for inviting me to this great symposium. So I hope everything goes right with the media. Yeah, it's not so easy without direct feedback of the people. So short disclaimer, I was involved in studies that were, among others, supported by GE Healthcare and AVID, and I was site PI for clinical trials on aducanumab, verobexistat, and idalopirdine. And yeah, so the development of aducanumab was before my time, so I had nothing to do with this. So Alzheimer's disease, what do we want for the future? We want to have an in vivo validated disease understanding, and we want to have a precise estimation of the underlying pathology and ideally a targeted medical approach to this underlying pathology. And if we can interfere early enough, we will have a prevention of significant cognitive impairment due to AD. And the aim of my talk is to demonstrate how PET imaging can be a tool to achieve this. Now I don't see the slide. Do you see the slide?
No, we cannot see the slide. Okay, now it's fine. Yeah.
So I think we can truly say that every AD case is unique. So there's an observable psychosocial dimension that we can immediately capture: social situation, the cognitive symptoms, the psychological symptoms, and the behavioral symptoms. And here we have indeed, when we plan our therapeutic interventions, already a tailored therapy. But what is hidden is the pathology. So we do not see, when we look at the patient, how much plaques, how much synaptic loss, how much neuroinflammation or metabolic changes are in the brain. And the link between pathology and the cognitive symptom is complicated by the cognitive reserve, which leads to a point where some people tolerate a considerable amount of pathology in the absence of symptoms. And so here we clearly need a therapy that directly targets the pathology. And what PET can do is that it can be used for an in vivo visualization of the pathology. The first traces that are used in Alzheimer's disease are water PET and glucose PET. And they provide an indirect estimate of synaptic loss and neuronal loss, because you know that the metabolic demand is coupled to the availability of synapses and neurons. And what we can also measure with water PET is the blood flow, and this is also indirectly measured by glucose PET. With the amyloid PET, we can measure the amount of amyloid plaques in the brain. And you know that around the plaques, we have this halo of toxic oligomers, activated microglia, which we can image with TSPO PET. We can image tau pathology in the brain. And recently, there's also promising data out on PET to image synaptic density. I want now to touch briefly upon the modalities. Here you see a water scan and an FDG PET scan in healthy subjects. And where there is red color, there is high metabolism in the brain. And you see that in MCI, due to AD, you have a reduction. For example, here in the temporoparietal area, in the precuneus region and in the frontal region. And what we can say is that FDG PET is the modality with the highest positive predictive value in the MCI stage. So if you want to make a short-term prediction who will get impaired in the next years, then FDG PET will be the modality you want to choose. If you want to look really more at metabolism, at perfusion, then water PET would be your gold standard. And it's interesting that, for example, young carriers of ApoE4, they have indeed a hypermetabolism, which might later contribute to the vulnerability to the disease. Moving on to amyloid PET. With amyloid PET, we can visualize the plaque pathology. And here you see a typical, on the upper right, you see a typical negative amyloid PET scan where the tracer lighting up in the overlay image is restrained to the unspecific binding of the white metal. In the middle line B, you see diffuse gray meta binding, and in section C, you see a local amyloid deposit in the occipital lobe. And what is nice for the clinical trials right now is that we can look directly what the substance does in the brain. So when you look on the picture on the left side, you see that there is an amyloid PET with PIP at baseline. And you see that in C, there is an amyloid-related imaging abnormality occurring in the FLAIR image. And when you look later at the PIP PET image, you see that in this region where the amyloid-related imaging abnormality was, you see a strong reduction in beta amyloid. So you know, in this case, the substance was bapineuzumab. There is amyloid removal taking place. For tau PET, I want to refer you to this excellent review by Loitzi in Molecular Psychiatry. And on the left, you see a three-dimensional image of a subject with AD dementia, Mini-Mental score of 14. And where there are red colors, there is tau deposition to a strong extent in the brain. You see it in the temporal area, spanning to the parietal temporal area, also in frontal areas. And what we got from the tau studies so far is that when the tau signal spreads to lateral temporal or parietal region, you usually have some extent of cognitive impairment or MCI due to AD compared to cognitive normals. But when you look on the images on the right side, which are from a publication from Lowe et al., you see when you look at the entorhinal area, you see that you can also image tau deposition there. So don't be distracted by this large blob. This is unspecific binding in the choroid plexus, but the small lightening up in the entorhinal cortex. And even if you see something here in cognitively normal subjects, this is associated with some extent of cognitive impairment. And what we have also confirmed with the tau study is that there's an overlap of tau deposition with hypometabolism and clinical symptoms. The picture is less clear for TSPO PET. TSPO translocator protein of 18 kilodalton is expressed in microglia, and we're only beginning to understand which microglia really overexpressing this TSPO. And there were also some issues with second generation tracer where we did not know that there is a polymorphism that influenced that binding. But to summarize findings here, generally in Alzheimer's disease, you can measure what there was not consistently demonstrated was that there is any correlation with PIP retention. And also some studies found that higher initial expression of this TSPO was associated with slower cognitive decline in prodromal AD or mild AD. And most recently, there are promising tracers for measuring synaptic density. For example, this publication by Chen et al. In JAMA Neurology. There is this tracer 11C UCBJ, which marks synaptic vesicle protein isoform A, which is expressed in most synapses. And they had the hypothesis that it's reduced in the hippocampus of subjects with early AD compared to normal controls. And when you look at the image and the arrow, then you see that high tracer binding is present in cognitively normal participants, indicating intact synapses. And in the subject with AD, you see that the signal is considerably reduced. And what was additionally promising in that study, which comprised about 30 individuals, that the signal binding in the hippocampus was correlated with a memory composites score and as well as with the CDR sum of box score. So we have maybe in future also a PET measurement for synaptic density when this really demonstrates its value in larger studies. An important development is that low dose PET seems possible due to improved image reconstruction using machine learning algorithms. So what they did, they used just a proportion of the data that you acquire with PET, and they did a simulation how much they may reduce the tracer that has to be injected. For example, for fluorobetapen with an amyloid tracer, there may be achieved a dose reduction of 99% if you use simultaneously acquired MRI and ultra low dose PET data. A study from Geneva, they found the same for FDG PET, where they state that they can reduce the injected activity to 5%. And so this really counteracts the argument that PET may be dangerous because you really get a strong reduction. So you get basically 100 amyloid PET scans for the radioactivity of one amyloid PET scan. But what still remains the problem for this PET is that you need a very sophisticated radiopharmacy that has a lot of tracer in the repertoire, and the setup of this tracer is not easy. And it still has the burden for the patient because you need to inject the substance and capture the images over time periods up to 2 hours. But I think this can be worked out in the future. So how do we use PET imaging now? So we use it for diagnostic purpose. I will not go into detail here. And we use it to select cases for clinical trials to reduce disease heterogeneity. And we use it for the characterization of the impact of the investigational medical products on pathology, for example, for the demonstration of the mechanism of action. This is data from the screening into the phase 1b trial on aducanumab, and this data always puzzles me when I look at it. Those of you who have already participated in clinical trials, they know how standardized the workup is. And here there was a standardized workup by specialists in the field. And the last screening procedure in this study was really the amyloid PET. And when the MDs suspected prodromal AD cases or mild AD cases, 50% only showed really a positive amyloid PET, which number decreased to 35% when the subject did not inherit an ApoE epsilon 4 allele. So this is really striking, because this shows that with our diagnosis, we are often really not diagnosing the underlying pathology. But we have to interpret this as well as with caution, because the biomarkers we have right now are not validated to predict the therapeutic response. So we validate them by separating healthy subjects from subjects with the disease, but not to predict the therapeutic response. And for amyloid PET, it has clearly been shown that a gray zone with subthreshold amyloid may exist, where on the long run, people have worse cognitive outcome. So where do I see the possible future use? I think it's important that we define early disease based on the extent of the pathology and not on cognitive measures, because cognitive reserve will really make this more complicated. So when you think of an MCI patient, there is no pathological cutoff between MCI and Alzheimer's dementia. It's just based on everyday functioning. And sometimes in people who work, we even make the diagnosis of dementia earlier, because there it interferes with everyday function and occupational function. So I think it would be good really to use for the patient selection the degree of, for example, tau pathology or synaptic loss or metabolic change. Or we define subgroups where we do then subgroup analysis in the trials, but truly not on the cognitive cutoff, but maybe on the pathologies that occur in these patients. Moving now on to the next slide, PET imaging is also used to characterize pathological changes due to IMPs. So IMPs means investigational medical products. And also data on aducanumab, where amyloid PET demonstrated the mechanism of action. When you look on the left side, you see that there is a dose and time-dependent reduction in the composite SUVR for the amyloid PET. And this is also nicely illustrated by representative PET images on the right side, where you see in the high dose the strong change in signal. So on the right side, you have the change in signal in the gray matter, which was published in the addendum to the original article. And with this, I'm already almost at the end of my talk. So here also the possible future use is dissecting pathological change on a multi-tracer level. I think that it should be possible to include multi-tracer PET studies in all phases of clinical trials, maybe not in all patients, which would be very expensive and would be very consuming for the patients, but at least in subpopulations. Then we could study directly the link between pathological changes induced by IMPs. So, for example, when you looked at the Congress presentation on aducanumab, they showed in, I think, about 45 subjects that a change in amyloid PET was also accompanied by a change in tau PETs, so that the substance also had some impact on tau. And I think we should extend this so that we can look, we have a substance where we modify beta amyloid. What is the link to metabolism? What is the link to neuroinflammation? What is the link to synaptic loss? And when we can link the pathological changes really to cognitive outcome, we understand what pathological changes are really important to achieve to have a better cognitive outcome, and we would end up with surrogate markers. And then what is also very important, and I think there's already groundbreaking work done and also introduced by the speakers before me, that we need to establish biomarkers that are more easily accessible. But the nice thing about PET is that you really can truly visualize the PET. You see it. You do not need to model it. You see it with your eye. But it's important to develop in these studies biomarkers that really can measure the change as well as the PET markers, for example, blood biomarker, metabolic MR markers. And I think in the end, the overall goal is to identify features that are really associated with a beneficial response to drug treatment. And when we understand this better, we can switch to maybe combining strategies and so on. But this is just the future right now. I want to end with this statement that I think that really evolving these clinical trials and strengthening the scientific perspective on the clinical trials, it really requires strong partnership between academic research, including specialists in biomarker analysis, and the pharmaceutical industry, and mostly highly motivated patients and partners. And I think we need to think how we can achieve this. And with this, I really want to thank you very much for your attention, and I hope that we can get a complete picture at some point. So these guys are already on their way. They have already discovered the evidence that Mars once had a lake. So thank you very much for listening to my talk and for your attention.
Anton, thank you so much. It was a great talk, and you have many, many questions. We will all discuss them in the panel. And so we will stop the broadcast here and just move to the panel.
Okay, thank you. Thank you very much for hosting this.
Yeah.